Everyone, we welcome you for the next session, which is sponsored from a Merck symposium, Time to Target Met with Vision. Our faculty for today is Dr. Ullas Batra, who will be moderating the entire session. He'll be joining us from the next hall in the next few minutes. He's the co-director, Department of Medical Oncology at Rajiv Gandhi Cancer Institute. Dr. P.N. Mohapatra, who is the Director of Medical Oncology at Apollo Cancer Hospital in Kolkata, and Dr. Senthil Rajappa, who is the Head of Department of Medical Oncology at Indo-American Cancer Hospital in Hyderabad. To kickstart the session and the discussions, we have a recorded session from Professor Paul Pike, who is the Clinical Director, Thoracic Oncology Service, and the Associate Attending Physician from MSKCC, New York, USA.
Presented by Michael Thomas at the World Congress on Lung Cancer, again, a couple months ago. And here I want to focus on results from cohort C, which was a confirmatory cohort for cohort A. Still many patients analyzed and accrued in this study. And the cohort C data was broken down by first line or second line results. These are patients who were identified either through tumor or liquid biopsies, so the entirety of the cohort. And here the first line data showed an overall response rate of 60% and a median PFS of almost 16 months, which really is quite good. This really reaches that kind of threshold that we have to be able to utilize a treatment like this in the upfront setting. The second line data was similarly good, although there was a diminution overall response to 47% and a median PFS of 12.1 months. And the Kaplan-Meier survival curves are shown on the right side, very similar results here. And the time-dependent endpoints being cohort A and cohort C, which is nice to see from sort of that level of confirmation. The other thing I want to point out from the data is that the median overall survival in the first and second line setting is about 20 to 21 months. Now, the reason why that number is so important is because we know from historical data, we know actually from data that was presented by Lee and colleagues in the Ipsos study at ESMO just about a couple weeks ago, that patients who are elderly, patients who have impaired performance status, their median overall survival is actually quite poor, between 9 to 10 months. And so you have a median overall survival of about 9 to 10 months in this elderly population, usually with first-line therapy. A doubling of that is not a small thing to 20 to 21 months. And so really that overall survival data has been quite nice to see as well in the VISION study. We also took a look at a subset analysis of patients treated with just a tumor biopsy results. And the reason why we focused on that population is because that's also how the other MET studies identified patients. And here the results look even better, for reasons I'll get to in a little bit in terms of what we think. Here the cohort C overall response rate increased to 62%. The median PFS was 15.9 months. Median overall survival was 22.7 months. And similar analysis in the tissue biopsy positive folks who were treated in the second line setting and beyond had an overall response rate that was also a bit higher at 51% and a median PFS just shy 14 months. So even better, robust data when we restrict things to just a tumor biopsy cohort. And the reason why we think we're seeing this difference was something that was presented by Enrique de Felipe at World Lung last year in 2021, which is somewhat of a busy slide, so you can just sort of listen to my voice in terms of untangling this. But the bottom line is that we think that the patients identified through liquid biopsy identify a poor prognosis cohort that has a higher tumor burden. This was seen both by some target lesions, which were higher in the liquid biopsy cohort versus the tissue biopsy cohort. And the number of lesions, target lesions, was higher in the liquid biopsy cohort. Data that I don't show here is that these patients tended to be more symptomatic at the time of presentation. They had higher numbers of unrelated adverse events at baseline as well. So overall, we think identifying patients by liquid biopsy identifies a poor prognosis cohort, which sort of intuitively makes sense. You need to have enough cancer present to shed enough DNA for us to detect. And so on balance, this is going to identify patients who have a higher tumor burden than those folks who are identified by tissue biopsy. You can see on the waterfall plot on the right side that a lot of patients who do have target lesions that are measurable at the time of enrollment do have responses in their brain metastases. We do know that the intracranial control rate remains quite high at 88%. The median PFS for intracranial control is 20.9 months. Overall response rate on the right side is 66.7%. We do know from preclinical studies also that tepotinib crosses the blood-brain barrier. Safety was an interesting thing that we've seen taking a look across all MET inhibitors in this space. And so here I constructed a chart that shows related adverse events for crizotinib, capmatinib, tepotinib, and savolitinib, which is pretty much all the MET inhibitors that have been tested in this space. And you can see that peripheral edema rates of any grade remain quite high, generally in excess of 50% across all of these drugs. And there really is no class of medication that has edema rates that are that high. And this really is a fingerprint for that safety signal that happens in conjunction with decreases in albumin and benign increases in creatinine. And we do think that this is some kind of treatment-related effect that we're seeing on the vasculature. The other thing that's interesting about peripheral edema is that the kinetics of the edema are quite different from other adverse events. Most of these adverse events, and I'm sure all of you are familiar with this, most adverse events from medications, they happen pretty quickly once you start the medication. Things like nausea, GI effects, increases in transaminases. Peripheral edema, though, takes a while to develop. The median time to onset is 2 months in the VISION data set. The median time to resolution is 67 weeks. This tells you that something is happening, probably physiologic, that takes a while to take hold. And then even with dose reductions and dose holds, it can take a while for that edema to unwind itself. The geometry investigators showed similar data last year for capmatinib. The median time to onset for peripheral edema shown at the top is 3.48 months, which is quite long. Similar increase in blood creatinine were 3.58 months. Median time to resolution also was quite long at 2.56 months. So again, the kinetics for peripheral edema as the kind of main side effect that we see with MET inhibitors is unique. In terms of the management of these related side effects, tepotinib-related side effects, a lot of this is something that we've gained experience with in treating patients on VISION. A lot of this has been spearheaded by our nurses and nurse practitioners who have taken care of these patients. And this is a good example of an abstract that was presented by our nurse practitioners last year at ONS, which shows a patient of ours, Memorial, who remains actually on study, remains on tepotinib for almost 3 years at this point. But you can see on the bottom panel, shaded in pink, that it took 11 weeks for this patient to develop grade 1 peripheral edema. Again, it takes a while for that edema to take hold. That grade 1 edema then increased to grade 2 edema, and the patient has had grade 2 edema pretty much since January of 2020. And the way that we've managed this is shown at the top in terms of the dose manipulations with the dose reduction, some dose holds that have been present as well to try to keep things manageable for this patient. And things have been manageable with dose holds and dose reductions in a way where she's been able to stay on. I think the important thing that we're seeing anecdotally is that those patients who have a response, where we've had to do these manipulations to try to manage edema, there's been no impact on the sustainability of this response. So it's one of those things where I think we just have to get used to doing these dose holds and dose reductions in order to manage this. Lasix tends not to work because this is not an issue of forward flow the way that we're used to for managing heart failure, so Lasix tends not to work. The other things that can help are things like compression stockings and leg elevation, the way we do for other kinds of edema. So this brings us now to really where we are in 2022, which is med exon 14 skipping, and testing for this is firmly ensconced in clinical guidelines. This is an update from 2020, where I highlighted in green the addition of med exon 14 skipping as a routine biomarker to test for in our broad molecular platforms. And the other thing is broadening of the recommendation for testing to all histologies, both non-squamous, not otherwise specified, as well as squamous cell lung cancer. And a recommendation to provide this now in the upfront setting based on the Geometry and Vision study for tepotinib and capmatinib, and that was a shift in the guidelines as well. So guidelines recommend giving this, and I think as we've seen, the data support this. As soon as you identify a med exon 14 skipping event, ideally in the frontline setting, then you provide a MET inhibitor. Now, in terms of how to apply med exon 14 testing, this is my algorithm for standard of care, and it looks a little bit complicated, but it's fairly straightforward because you need only follow the hierarchical tree based on the results that you find. But the important thing to note is that none of the algorithm works unless you do tumor or liquid biopsy NGS testing. Unless you identify the relevant actionable oncogenic driver, you can't go down the algorithmic tree. And so the most important thing to do is actually broad molecular testing on all newly diagnosed non-small cell lung cancer patients. It doesn't matter if you're looking for a MET exon 14 skipping alteration or an EGFR mutation, you just need to do the testing so you can hopefully identify one of these alterations. Because of what we saw at the very beginning of my presentation, which is finding a targeted therapy, providing one of these for an oncogenic alteration we find in a patient matters an enormous deal, and arguably more than when we give patients, for example, immunotherapy-based treatments. So that's it. Thank you for your attention for today's talk.
Now, for leading the panel discussion, may I please invite Dr. Ullas Batra and Dr. Senthil Rajappa and Dr. P.N. Mohapatra to please join him for the panel discussion. So.
Okay. So thank you. And after that nice talk, we'll be talking about more about targeting MET with the vision. And my first reactions when I saw the word vision in the trial is vision is the art of seeing what is invisible to others. And who better than the esteemed panelists of Dr. Senthil and Dr. Mohapatra to show us what is invisible. So that was one. My subsequent reaction over here, we can have a normal vision or we can have a tunnel vision. So tunnel vision is only speaking about the tepotinib, and normal vision will be, kind of sequencing, immunotherapy, how do we test, how do we do, and then discuss about, whether we want to give tepotinib. Okay, the objectives are basically two. So one is to highlight the importance of testing for MET exon 14, and secondly is how to treat. So tepotinib is a once daily highly selective MET TKI approved for MET exon 14 as NSCLC. The inclusion criteria over here is something which I would like to show everyone. You look at this: advanced non-small cell lung cancer, EGFR ALK wild type. They have not taken ROS and all histologies. So they have taken squamous cell, they have taken adenocarcinomas, they have taken NSCLC NOS. I'm sure they have obviously not taken a small cell lung cancer. There were two cohorts, three cohorts, cohort A, cohort B, cohort C. So cohort A was basically the primary analysis, C was the confirmatory analysis. And this also basically showed that, I'm just showing the data, that there was a median age of 71 years, half of them were male, half had smoking history, and most had adenocarcinoma. But 25 to 15% of patients did not have adenocarcinoma histology. So my first question here is, I'll start with Dr. Senthil first. Senthil, are we testing for all squamous cell carcinomas also now, NGS?
Yes, Ullas, we are doing that now.
You're doing that now. Is
Yes.
there a paradigm shift?
Yes, a shift, but it's taken place maybe a year, couple of years since.
So you are testing for all smokers with squamous, non-smokers with
Yes,
squamous?
so
everything?
initially we used to do non-smokers with squamous, but over time we've started doing smokers also, because you end up picking up something like this, which is not the
Druggable.
common ones that you look at, because all these recommendations were with EGFR Alcross. I think now we have moved beyond that. And when you move beyond that, then you now see that 50% are smokers, squamous is in, so I think we need to widen.
So, Dr. Mahapatra sir, are you also doing squamous? Because
Same actually, we started with non-smokers, now we are doing all patients actually.
so all squamous,
All squamous,
all
we are
squamous cell
advising to do.
carcinomas also. And what has your result been? Because that's a statement. Last time I know, I think 2 weeks back, I was there with the Kumar in a panel discussion, and Kumar and I were the only ones who were saying that we will do NGS in squamous also, and everybody approximately were, denying that. So that's
I was not on that panel.
you were not on that
Ullas,
panel. You were
thanks.
not on that panel. So, what have you got in squamous cell NGS?
So, the last that I can remember is a EGFR T790M. Interestingly, it was a germline. So, I always had this slight lack of belief that this is really the driver to, in fact, to allay everybody's fears. I started with some chemotherapy. Now I put him on osimertinib maintenance. So, so slowly, as you see more, you believe more.
And are you getting some KRAS and BRAFs and ALK and everything?
I am yet to see a ALK. I've seen plenty of RAS.
Okay.
So not the G12C, G12D, and all these less common RAS mutations. So as we discussed last week in some other meeting, the more you're doing, the more you're seeing, and then you start looking at what are the
I would
possibilities.
actually agree with him, and we have just done a 90 patients whole exome sequencing of squamous, and our and in Tata's EGFR rate is around 6.8%. Ours is 4%. We have actually got 4 ALK. We have actually got 1 ROS, 2 BRAF, and 1 met exon 14. So, as Senthil very rightly said, the more we are testing for squamous, the more we are testing, we are becoming concerned, we are becoming convinced that there is a need of testing this also, which is very, very important. So, I think, and the NGS testing thankfully has not been that costly anymore. You have coupons and you have not so coupons, and you can do the remaining testing very, very easily. It's worth giving it a shot actually. So, let's say out of met exon 14, let's say you have I have a question on this then. So, this is what basically said, in adenocarcinomas, in NCCN says you should do molecular testing. In squamous cell carcinomas, you do consider mutation testing. We are very, hell-bent on following the NCCN guidelines. They also have suggested to consider testing, and that is something which is supposed to be done. So, that's not something which I am going to pay. There's something which Vivek Agarwala and Dr. Parekh will pay. Dr. Mahapatra sir, which MET alteration do you look for in your clinical practice? Do you look for an exon 14 splicing mutation, a point mutation, a fusion, or an amplification? A lot of time people send us reports. So, what do you look for?
See the MET exon 14 speaking, and also we are skipping, we are also seeing now MET amplifications actually.
So, what is more druggable what is more druggable as far as you are concerned?
I think skipping is more druggable.
Yeah, so that is again very, very important. So important thing over here is to realize that the approvals right now for both the drugs, whether it is the tepotinib drug or the other drug, is basically for MET exon 14. You do get MET amplifications. 40% of patients who are progressing on osimertinib will get a MET amplification. There you have a trial going on in which you give OC plus savolitinib, or you give OC plus some other drug, at that time. But predominantly the approvals are basically for MET exon 14 alteration. Now this is very, very important. I thought, let's not have only look at tepotinib and tepotinib. How do you look for that? IHC, FISH, RT-PCR, liquid. So liquid biopsy, NGS, DNA, RNA. Senthil, I'll ask you to, since you have a flight to catch.
RNA NGS is probably the best one to use.
So RNA NGS is the best one. Somebody gets a MET exon 14 on IHC.
No, I would, so
You
I would say,
discount that.
yes, correct, absolutely.
Okay.
Because
So
I don't think skipping mutation is something that you
It's
can pick up
something
on
which
an
can be
IHC.
fixed over
You
there.
can pick
Absolutely
up maybe the amplification on an IHC, but
So
not.
this is something which is very, very important. I did think when I saw the videos yesterday, the students would be there. IHC fish is a no-no. If you have a primer-based PCR, that is a yes. A liquid biopsy is a yes. Or NGS RNA-based definitely is a yes. RNA preferentially. We do confirm it again by DNA also, and I think that is what Senthil was telling me, that they were picking up less of MET exon 14 on their NGS, so they went back and saw them. Again, which I spoke to them in that session over there, it's very important to talk to your molecular pathologist, talk to them, what exactly are they doing, how are they doing, why are we not getting something. There has to be a good concordance and a cohabitation between a medical oncologist and a molecular pathologist. So this is about DNA versus RNA based methods. We are not going to discuss this. What about liquid biopsy? Senthil, or Dr. Mahapatra first, sir.
We try to do tissue biopsy. If tissue is not available, we do liquid biopsies actually.
So is liquid biopsy stood the test of time in your clinical practice?
Actually, liquid biopsy is supposed to get the results earlier actually, so that you can get a treatment decision. And
It is
still
supposed
if
to.
you
What happens actually, sir?
Huh?
It is supposed to get, sir. What happens actually? What happens on the ground?
Actually, see, we don't in Calcutta we don't have a liquid biopsy, and we have to send, and that takes some time actually as tissue biopsy. But so if we have a tissue, mainly we focus on the tissue to get a biopsy. Otherwise, actually, if we have a
It's tissue biopsy. You don't have to be apologetic towards that, sir. That's absolutely all right. Senthil.
Tissue, just like you have done in your institution, we looked at 100 matched samples just now. And liquid is picking up less compared to tissue.
Okay.
So both of these were done on standard, good quality NGS, not the one that I was discussing with you the other week, right? So liquid in our study is picking up 18% less compared to tissue.
18% less?
18% less.
That's
In fact, contrary to what we see in publications, the liquid picks up some 16%, and both of them are complementary in whatever we've seen in our 100 patients. I think it's 1% or 2%, I wouldn't say better pickup, different pickup by the liquid compared to the solid. So
I think that is the point that Kshitij had asked, Dr. Kshitij had asked over there. Liquid biopsy is not in the other hall at that time. Liquid biopsy in our setting right now, I am not talking about Guardant, I am not talking about FMI, I am talking about the local and our institute's own thing. We are not really picking up the fusions that well, that is one. The mutations are good, we are definitely picking up that, but there also, it's not 80%, it is somewhere around 70%, 65% as far as we are concerned.
That's correct. I told you about 18, so that's about 80% pickup.
Yes, that is what is the concordance rate
That's right.
between two. But it is definitely not faster. It is not faster. I mean, it takes time. It takes more time actually, and because they have to look for the samples. When their 5 samples will get finished, then only they will run. They will put the run.
Agreed.
So that was about the diagnostics. So we should test for MET exon 14. NGS is very, very important. PCR, RNA based NGS is very, very important. IHC and FISH is not, and it's not as uncommon as people feel. It's reasonably okay. So let's go to the how do we treat these people. So let's say we have a 60-year-old female who has a stage 4 non-small cell lung cancer, and biopsy from the lung mass is negative, is adenocarcinoma. EGFR AL cross is negative. PDL1 is 70%. So Senthil, since you have a flight and you want to finish it up earlier, what would you do?
I will send for a NGS.
Okay.
Right. If she warrants starting chemotherapy, warrants starting treatment, should I say, rather than saying chemotherapy, then I'll start her on chemotherapy and then wait till the NGS comes back before I make my decision on
You will not.
what else.
That's what everybody is now doing. You will wait for the NGS report. You will not add immunotherapy right away because we all feel that immunotherapy may not work in biomarker driven people. Now this is how the NGS report actually came, and if we can see here, the MET exon 14 is actually positive, and this is how the report came. Now Dr. Mahapatra sir, question for you. Now, if you had started on chemotherapy before the arrival of the NGS report, so you have given 1 cycle of PEMCAB, what would you do now? Will you change to single agent immunotherapy, that is Pembro? Will you put Keynote 189? Will you put Vision? Or will you continue the same?
I will change to MET inhibitor actually.
So first line MET inhibitor, is that
yeah,
what you are trying to say?
historically they don't respond well to chemotherapy, and immunotherapy what data actually have, it is very poorly responsive to immunotherapy.
But that data is from the second line data. Single agent immunotherapy may not actually act over there. So Senthil, what will you do?
I would also change, Ullas. So the reason why I'm saying I will change is if you, though this is again cross comparison of one cohort to the other. If you look at the numbers look a little more impressive for the first line cohort compared to the second line cohort. With a difference in response rate of over 10 to 15%, 3-4 months of difference in PFS and so on. So though this is not, level 1 evidence to say that it works better in the first line, but I'm tempted to say that I will use it in the first line rather than keep it to the second.
And obviously the
Tablet
lure
is a
of
tablet.
an oral drug, the lure
Tablet
of an
is a
oral
tablet
drug,
at the
people
end
not
of the
coming and eating your brains for every 3 cycles is absolutely fantastic. Is there a difference? Now there are 2 people, who are waiting with bated breath to answer this question. Senthil, this goes to you. Is there a difference between a Novartis and a Merck? I think Pfizer, we will leave it out for crizotinib, nobody will give that. AstraZeneca is not yet there. So is there a difference, or you think?
Okay, so there is no head-to-head comparison to say that there is a difference. So all the data that we have is cross comparison, some matched pair analysis, doing those weighted analysis and so on and so forth, in which it looks like in the first line there may not be much difference. In the second line, the response rates and numbers seem to be slightly in favor of tepotinib, but all this needs to be interpreted with a bag of salt.
Let's not torture the data enough actually over there.
So I would say both of them use a MET inhibitor.
Use a MET inhibitor, and depending on which symposium do you go to, use the C word or use the T word.
If
over
it was
there.
in the next room, I'll say something else. If it is in this room,
But use a MET inhibitor. Do not use immunotherapy. Do not use chemotherapy. If a patient is affordable. Crizotinib also, I am not so sure because it's going to get cheaper. I mean, the point is crizotinib is going to get 15,000 rupees from January onwards. Crizotinib doesn't cross the blood-brain barrier, the PFS was lesser, the response rate was 36%. So I think, crizotinib is not a poor man's MET inhibitor. If you really want to go ahead, please don't give crizotinib, give chemotherapy, and then second line let the patient get some money. Is that a fair statement?
correct. Use it at some point in time.
Yeah, so use it somewhere point of time. Fantastic. So this is the data regarding immunotherapy in MET exon 14 splicing mutation. Guidelines now recommend MET inhibitors in the first line, both the drugs in the first line. Now this was a vision study basically which showed, was shown over here. Cohort A was a primary analysis, cohort C was a confirmatory analysis, and a duration of response of 32.7, median PFS of 15.3. 15.3 is what you get with the second generation EGFR inhibitors. And overall survival of 29.7 months. Small number of patients, yes, but that is what actually we have got. This is what Dr. Senthil was talking about. If you look at first line, cohort C, it is an overall response rate of 60% in first line, a median duration of response not reached, median PFS 15.9. If you go to second line, the response rates come down, the median PFS comes down. And we all know that 1/3 of the patients may not take treatment in the second line. So, nothing can be more unforgiving to a medical oncologist or a patient than if you have an oral drug available and you have not been able to give. So, to me that is criminal. If you have an oral drug available, target therapy available, you should be giving that. Are we going to I'm not saying throughout the radiation oncologist, a patient has asymptomatic brain mets, Dr. Mahapatra sir.
Actually, I have to, there is no point in giving any local therapy. Start with MET inhibitor because they have a PFS, they have a response around more than 60% with disease control at more than 80% actually.
Have your radiation oncologists also become aware of this fact, Senthil, or they still want to give this thing? I mean, that's a very important question. We are convinced. Are they convinced?
There are some things you don't take to the multidisciplinary board, isn't it?
Okay.
So that is within your discretion, right?
So that is where I told, Senthil will say something invisible, which is, that is why Senthil is over there.
So sometimes you have to work with a vision.
Yeah, so that's how you work with the vision. Do not take them to MDTs, give this thing, have a response, and Dr. JP Agarwala is saying no. So we are not, that's a tunnel vision. We are not listening over there. So again, what we say is there is a 88% response rate. Again, I think if a patient is asymptomatic, doesn't really require urgent RT, we can safely omit Dr. JP, and I'm not looking at you. So this is what I feel is on the pink or whatever this shirt is, Dr. JP Agarwal saying the brain meds guy, and the brain meds guy is going towards Senthil in medical oncology there. So this drug also crosses the blood-brain barrier. Safety, your experience, that's the last question.
They're safe enough, Ullas, like what Dr. Pike was explaining, all those things. So, but for the edema, everything else is.
So I think the three main issues have been weight gain, nausea, vomiting, and increased creatinine. Please don't get worried about increased creatinine because it is because of the inhibition of the MATE receptor. You will have an increase in creatinine, but it will not really make much of a difference. So I think liquid biopsy I'm going to skip. It's got a once daily dosing and a simpler dose reduction. Has our vision for MET exon 14 become a reality? Dr. Mahapatra first and then Dr. Senthil.
Definitely.
The geometry of the vision has become very, very good.
3 to 4% of
Patients have become
positivity is not actually.
Okay.
Yes.
So yes, the simpler answer is yes, you have a drug available. It's not like a KRAS sotorasib, I think, which came with a huge hype and now it is slowly fizzling down. It is really continued from where it is. And that's what is very, very important. My last slide, it's not what you look at that matters, it's actually what you see. And what you see is probably what is ordered, and that is what I was talking about in the side room. Order the test. That is the most important thing. And the vision for everybody has become very, very clearer. So thank you, Dr. Senthil. Thank you, Dr. Mahapatra. And have a safe flight back home, Senthil. Bye. Thank you.